Thank you, Alberto. Hello, everybody. For the next 15 minutes, I'll be discussing the role of MRI for assessing metastatic bone disease, focusing on the MET-RADS system. Here are my disclosures. So what is MET-RADS? In the official publication, MET-RADS is Metastasis Reporting and Data System. But sometimes I say it's Metastasis Response Assessment and Diagnosis System, and you'll see that this is truer to the actual contents. Why do we need it? To overcome the limitations of current diagnostic methods when assessing bone disease, in particular, as already discussed by Alberto. So the MET-RADS standard aims to meet a number of requirements, and one of these requirements is to establish the minimal parameters for whole body MRI data acquisition that is suitable for quantitative analysis. And this publication in the British Journal of Radiology covers the technical aspects of quantitative data acquisition. The MET-RADS standard defines two protocols. One is based on lesion detection and characterization and is called the core protocol and consists of sagittal T1 of the spine, a stir sequence, an axial or coronal Dixon technique, and diffusion imaging with very little else. So here is a typical core protocol that should take less than a half an hour. Sagittal T1, stir, coronal Dixon technique, 4 stations, diffusion weighted imaging, and then a MIP reconstruction. The comprehensive protocol is more extensive, as you might imagine. It has axial and coronal Dixon techniques. It uses more B values, and there is a need to perform axial T2 weighted imaging for anatomical correlation. So here, for example, is the comprehensive protocol done at 3 Tesla on a patient with prostate cancer. Again, you can see stir T1 coronal Dixon reconstructed as fat fraction images, axial Dixon reconstructed as fat fractions, T2 weighted images, which is compulsory, and diffusion weighted images. And it's these diffusion weighted images that are made into these MIP images. And here you can see that there are 2 abnormalities that you can focus down on. So if you look at the first abnormality in the dorsal spine, you can see that this is an area of fat poor bone marrow, but the comprehensive system allows you to do smaller field of view images. So this area of abnormality on the B900, on the B800 image is seen to represent internal iliac lymph nodes in this patient with prostate cancer. We almost always do a UTE sequence of the lungs, either in the axial or the coronal planes. This is a very short breath hold. We always also do flare sequences of the whole brain, and this enables us to look at metastases, osteonecrosis of the jaw, for example, and if we need to give contrast, then it's possible to do, but the entire examination should be completed in 1 hour. So here is the full list of sequences and reconstructions that need to be undertaken for the core and the comprehensive protocol. Another aim of the MET-RADS standards is to develop criteria to objectively assess response of metastatic bone disease, and this is called the MET-RADS criteria, and then summarize the likelihood of response being present in both bone and soft tissue disease using a Likert-like scale. In this scale, 1 and 2 represents response highly likely, 4 and 5 represents progression likely and highly likely, with 3, of course, representing stable disease. Now for the bones, we've had to take criteria that we've been aware of for many years and codify them into a response assessment category. So a response assessment category of 5, progression highly likely, would include features such as an unequivocal increase in the number and the size of lesions, an unequivocal new focal or diffuse area of metastatic infiltration. Now you'll notice that there are no diffusion criteria here. The only diffusion criterion related to ADC is that any signal change that you see emerging would have to have a ADC value between about 650 and about 1200, which represents the active range for metastatic disease. So here's a typical example of a patient who's progressing on STIR sequences, on T1 sequences, and on the diffusion sequences. And here is the corresponding ADC histograms. You can see the volume has increased dramatically from 70 to 600 cc's, but you'll notice that the ADC changes very little. A positive response is characterized by the disappearance of lesions, as you might imagine, or the disappearance of soft tissue disease or lesions that become smaller. But we have incorporated ADC changes. So, for example, response highly likely, response assessment category 1, is the return of normal marrow fat in areas that were previously infiltrated. But you'll also notice that there is a criterion that includes ADC values. So if ADC goes from below 1400 to above 1400, for example, or a 40% increase in ADC from baseline values, that would equate to response highly likely. So here, for example, is a patient with prostate cancer treated with docetaxel chemotherapy. You can see on the T1 sequence, it looks a little bit worse, if anything. The STIR sequence is about the same, but on the diffusion sequence, it's quite obvious to see that the signal intensity has dropped. The retroperitoneal lymph nodes have also reduced. And if you do the segmentation of the bone marrow, you can see that on examination number 1, you have a low ADC value, and we said it should be between 600 and 1000. But look what happens after treatment. You see an increase in ADC value. Another aim of MET-RADS is to standardize the data collection so that it enables us to get a detailed report on the distribution of disease based on the common anatomical patterns of metastatic disease spread. So for example, in the prostate, locoregional disease would be prostate and pelvic lymph nodes, skeletal disease are the usual body parts, and soft tissue disease would include retroperitoneal lymph nodes, other lymph nodes, liver, lung, and other sites. Of course, for breast cancer, this would be quite different. So for breast cancer, the primary tumor axillary lymph nodes would constitute locoregional disease. Again, you've got the different skeletal sites, but you can see the soft tissue disease is different. For example, we've included brain on this side, and other soft tissue sites are also included. For each of the sites, you have to assign a response assessment category. So for each region that we just talked about, you have to decide whether there is or there is not metastatic disease present and its response. And then you have to decide what is the primary response assessment category in that region and what is the secondary response assessment category in that region. So the primary response assessment category is based on the predominant response in more than half of the disease volume in a region, and secondary response assessment category is the highest non-predominant response within the same region. So for example, you've seen this person before. Here's the patient that we saw previously who is progressing. Here is the standardized report, but here is the case report form for prostate cancer. So you can see for each region we say whether there is or there is not disease. So for example, in the lumbosacral spine, there is disease. The majority of the lesions are progressing, and the highest category for the next for the other lesions is also 5. So this is a 5-5. Here in the left axilla, it's quite interesting to see that is there disease? Yes, there is disease. What is the highest response assessment category is 5, because you can see this lesion is increasing in size. Other lesions are stable, so it becomes a 5-3. And in this area here, you can write bladder and rectal involvement and give a summary of what you think is happening in the nodes, in the viscera, in bones, and at the primary site. Here's the same patient who was responding to therapy, and again you have to say whether there is or is not disease there. So in the lumbar spine there's still disease visible, and you saw that on the T1 and the T2 sequence, but the majority of the lesions are responding, and this is 1-1, and you can write in here an excellent response to treatment at all disease sites. Another aim of the MET-RADS standard is to provide a method to record the presence, the location, and of course the extent of discordant responses. And this enables you to gauge the depth of response and the heterogeneity of response, which can then be incorporated into the clinical routine. And here is an example. So this man has prostate cancer being treated with abiraterone. What you notice is that the retroperitoneal lymph nodes have responded well. In fact, there has been some progression in left groin lymph nodes, but you also notice new bone metastases. So this is a classical example of discordant response or heterogeneous response in a patient with metastatic castration-resistant prostate cancer, and you can capture that. You can capture it by saying things like, in the pelvic lymph nodes, the majority of the lymph nodes have responded, but some are stable. In the groin lymph nodes, which would constitute other nodes, you'll see that there is disease present, but the majority of the disease has progressed. This is a way of capturing discordant responses. So what are the next steps for MET-RADS? There are a number of validation steps that still need to occur with MET-RADS, and these are beginning to be seen. Here, for example, is some data that was recently published looking at the volume of disease and how it predicts for cancer-specific survival using the MET-RADS standard. The inter and intra-observer agreement for the response assessment categories has also been looked at, and you can see that for the bones, the primary response assessment category tends to be either substantial or excellent, but you'll notice that the secondary response assessment category is moderate to substantial. So there's greater variation in the secondary response assessment category compared to the primary response assessment category, and this is probably related to the experience of the readers. So in this particular instance, you can see that the second reader was less experienced. So here are my take-home points. MET-RADS provides the minimal standards for whole body MRI reporting with diffusion-weighted images. It gives you guidance on image acquisition, interpretation, and reporting, not only at baseline but also at follow-up in patients with advanced metastatic cancer, predominantly for breast and prostate cancer. It is suitable for guiding patient care in clinical practice. It incorporates morphological assessments as well as ADC assessments, but clearly further validation is required into this area. Thank you very much for your attention.